we move on now with the next talk, which is kind of leaving the field of cancer. No, not really. It's the first step in leaving the field of cancer. It's Professor Joris Vermeersch. He's leading the Laboratory of Cytogenetics and Genomic Research at the Department of Human Genetics in Leuven, Belgium. And he's director of the Genomics Core in Leuven. And he's telling us about detecting cancer via non-invasive prenatal testing. I have to say we found that 3 times in our lab. And the 3 times we really transferred these results, we were right. It was 1 breast cancer, 1 colon cancer, and 1 myelodysplastic syndrome. So that's possible. And we are curious what you can tell us about this.
Okay, thank you very much. Do you see my screen actually?
No.
No, then I'll try to share it again.
Yes.
Okay, so, sorry, this is of course not what you want to see, but I think now you see my full screen, correct?
Yeah. Yeah.
Okay. Well, first of all, thank you for the invitation to present the work on cancers in pregnancy here. It's always hard to talk after Michael Speicher. It's of course so complete. But the advantage I have is that I switch indeed gears. We move from cancer to prenatal care. That's where I came from. And that's how the team rolled into cancer. Just briefly to say that I think most of you know that in addition to cancer, cfDNA screening is big for prenatal care. And this is just a protocol most labs use, but not necessarily all. We extract plasma DNA, make libraries, sequence, and then we do genome-wide analysis. The way we do this is we divide the DNA up in 50 kb bins and then look at its course across the genome. We started NIPT in 2013, and in 2017, actually, Belgium was the first country where all pregnant women can have a non-invasive prenatal screening free of charge, so they don't pay anything. In 2017, we also changed the care pathway in prenatal care, where NIPT replaced basically the combined screening test, so that's completely abolished. And when we get out of these analysis, we compiled the data from 2 years analysis in Belgium, and of course we detect the common trisomies. That's why we set up the test. That's the aim of the test, is to detect fetal trisomies, and so the incidences perfectly map what can be predicted based on the age of the pregnant woman. In Belgium, the average pregnant woman has an age of 30.7 years. And so in 0.3% of the cases, we see trisomy 21. But of course, we're sequencing, not only we detect fetal chromosomal aneuploidies or these 3 trisomies, we detected all chromosomal abnormalities across which are present in the fetus and the mother. Only 5 to 10% of the DNA is derived from the placenta, and we detect much more. And the question we had early on was, what should we do with these incidental findings? We asked advice to the Belgium ethical board, and they told us that we should report clinically relevant aberrations. And so one of the typical types of aberrations we find are chromosomal, rare autosomal trisomies. And the rare autosomal trisomies most often are derived from the fetus. And if we follow up on them, only in a minority of cases we find the aneuploidy back in the fetus, in about 4 to 10%. It depends a little bit on the study. And the majority, what's interesting actually, and this is just some data which hasn't been published, is that we now know that in 50% of the cases where the non-invasive prenatal screening detects a NIPT, we actually find pregnancy complications. And of course, I think that's we believe that's very relevant for clinical care. These pregnancy complications can be fetal aneuploidies, and as I mentioned, in about 10% of the cases in our prospective study. But these rare autosomal trisomies also lead to preeclampsia, gestational diabetes, they lead to some intrauterine growth retardations and so forth. And the other interesting thing was that in this study is that there's the incidence of pregnancy complications is equally high in the cases where subsequent placental follow-up or invasive testing could not identify the rat identified by NIPT versus the ones where we could identify it, showing that the NIPT is probably more accurate. It samples the whole, the CF DNA contains DNA from the complete placenta, whereas individual biopsies are localized, and therefore we miss actually the aneuploidy. I just mentioned that because it's important. In addition, we report segmental imbalances in the fetus. We report maternal imbalances, which are clinically relevant, which can be, for example, deletions in cancer predisposition genes. We do report BRCA1 deletions or MSH1 and so on deletions, but also other clinically relevant mutations and deletions and duplications we detect. We've published on those separately, but today I was asked to talk about our cancer in pregnancy, and in this cohort of 150,000 samples, we picked up a cancer in pregnancy in about 1 in 10,000 NIPT. So they're not very frequent, but nevertheless, of course, very pronounced. And just I don't need to explain this to this audience. I'll try to stick to my time. So we know that not only the placenta, but also the cancers shed DNA during in the bloodstream. And just to go back 10 years ago, this was the very first profile where we didn't know how to deal with it. So we had this profile where the different chromosomes had segmental deletions or duplications across the genome. So the first thing we think is, okay, maybe something is wrong with our test, so let's take another sample. And the second sample showed the same aberrations. And of course, we did an invasive test just to make sure, but already we thought that's very unusual to be in the placenta, and the placental test was normal. So we thought maybe this could be a cancer. Now, I think everyone would think alike. At that time was unexpected. And then to zoom in which cancer it could be, this woman was sent for a whole body MRI, a diffuse weight whole body MRI image, and we found this non-Hodgkin's lymphoma, or this lymphoma there, which was then biopsied and shown to be a non-Hodgkin's lymphoma. And it's actually quite interesting case because non-Hodgkin's lymphoma, it's a Hodgkin's lymphoma, I'm sorry. The Hodgkin's lymphoma is actually characterized by the Reed-Sternberg cells. And so Reed-Sternberg cells make only up 1% of the critical mass. And so all the rest is actually immune cells surrounding that. Nevertheless, the cancer profile we identified matched actually the FISH profile of these Reed-Sternberg cells, and Hodgkin's lymphoma were notoriously difficult to study genomically because of this low percentage, but apparently the turnover of these cells is so high that we can actually just detect that very nicely in the blood. But I also forgot to mention, of course, this woman didn't know she had a cancer, so this was an indolent cancer. And so since then, we have had many other case reports where we, and collectively, we wrote up a paper on just all the cancers we detected during this, in this large cohort study. And basically, this is maybe a little bit small, but in these 87,000 or 88,000 cases, NIPT samples, the majority of those were perfectly normal. In 2 cases, we detect clonal mosaicism, which we believe is not in the fetus, but is actually maternal in origin, because we always take the white blood cells and then do the analysis of the white blood cells. So we know, and clonal hematopoiesis, which results in a single chromosomal aneuploidy, can confound your NIPT screening, because you see an aneuploidy, you can think it's a rare autosomal trisomy in the fetus, but actually it's clonal hematopoiesis. On the other side, we have a series of samples where we have non-interpretable results. Amongst those are those with multiple copy number variations, and we had 16 of those cases actually, and 15 of those could be confirmed to be a pregnancy. One of them actually only 2 years after the detection of the aneuploidies in the pregnancy, showing that actually cfDNA can, of course, detect the presence of cancers way before they really show up later and become aggressive. If we look at, this is the summary of all the copy number profiles, and you see we're not going for very sensitive detection. We're going for, or we're reporting back only those cancers which are so blatantly obvious, having multiple copy number variants detected in the cfDNA, that we cannot but report them back. On the right, you see the different cancers we've identified, not surprisingly, a number of blood cancers, leukemias and lymphomas, but also a series of all other cancers, breast cancers, we have some sarcoma, ovarian carcinoma, and so forth. So that's our study. We're not alone, actually. By now, there's 5-6 large studies with 2 million or over 100,000 pregnancies, and we see the same kind of numbers coming back in these different studies. They're also across the world. We have a Chinese study, we have the American study from Diana Bianchi, we have the Trident study in the Netherlands, and all of them have a series of cancers detected, and the PPVs vary, and that depends a little bit on the probably the cutoffs, the sensitivity at which one sets the limit to report back certain cancers. If we look at the types of cancers, the lymphomas are most pronounced, and we see the breast cancers, which are quite common in this population. But for this group, maybe interesting, we see also the colorectal cancers, liver cancers, and so forth. And there's a whole series, basically all potential cancers, which you talked about during the meeting earlier. And so that led us to provide or suggest this flow. NIPT is usually done in a genetic center or in a genetic testing laboratory. So the idea is that once you detect this type of cancer or potential cancer in the ctDNA, we reach out to the obstetric unit. Usually it's clinicians, clinical geneticists that reach out to the people, and we have a strong link. So we have an oncology and pregnancy unit where these people are referred to and then followed up. We feel it's very important that we send those people or immediately start treatment. We have a cancer in pregnancy treatment group that has shown that earlier treatment during pregnancy does not affect the placenta and the fetus in most cases, and therefore treatment can be started immediately. The reverse question can be asked also, how about some people, some women become pregnant while they have a cancer? And we did a small study on sensitivity of NIPT to detect, or this methodology. We call it GIPSEC just because it's not NIPT anymore. Here we're using the methodology just to detect the cancers. And so we had 19 patients with breast cancers and 27 non-pregnant breast cancer patients. And if we look at these profiles, of course, we do detect the profiles in the ctDNA which match actually the tumor DNA, but that's what you've already heard in the meeting. What was a little bit surprising, but the numbers are extremely small, so I think this needs to be extended, this study, is that we had a higher sensitivity of the profiles or of breast cancers during pregnancy compared to non-pregnancy. But I think we need to further study this. For the sake of time, again, this is a demonstration that the ctDNA matches the tumor DNA. We can also use this methodology to screen, but I'm just going to skip this. I think you discussed much more sensitive methods to screen and monitor and treatment than copy number profiling. So this is also done. So what we should be aware of if you're in the prenatal setting, that we should not actually screen. If you know that a woman has cancer, we should not use the NIPT to evaluate the presence of fetal trisomies, because the tumor might actually confine the the detection, and it might lead to false positives and false negatives. And we kind of extrapolated from all the data how many times we would get false positives or false negatives based on the aneuploidies detected. And this is a little bit, we expect 15% of the, if in the case in the presence of a cancer, you have a 50% chance that you resulted, that the NIPT would result in a false positive. And so it's definitely something we should be aware of. So I think reporting the cancer is also relevant to do a correct interpretation of your NIPT results. So in conclusion, I would say cancers during NIPT, yes, NIPT allows pre-symptomatic detection of cancer in pregnant women, which allows early cancer treatment. We really think that's an advantage. It can be used to monitor the treatment and the relapse, and also sometimes we use the methodology to follow some women postpartum just to see whether or not signals remain or disappear after delivery. Obviously, we can improve the sensitivity of the methodology. We're very conservative. We estimate that about 1 in 1,000 to 1 in 2,000 women have cancer when they are pregnant, but they don't know it yet, or they know it. So that's the population estimate. So we're picking up only 1 in 5 of those women. So I think here's an opportunity to improve if we feel that's the direction. Of course, the women do not come for a cancer screen, but maybe it's not a bad thing to have. Of course, it spoils a little bit the pregnancy. And so because of all these questions, we have a lot of questions remaining. We're wondering, or different teams in Belgium, we have made guidelines. I know in the Netherlands, they're also creating guidelines. So we're now working at we're wondering, should we extend those guidelines, how to counsel a woman, how to organize the clinical path, but also can we when should a laboratory report a NIPT as a cancer? Laboratories are very wary about it, definitely in the US, for liabilities, for not reporting, but also for reporting too fast, because that has consequences. We should try to understand what is the positive predictive value and negative predictive values. And we also wonder how much can we prove the clinical utility? To what extent does it make sense to report cancers earlier in pregnancy, and does it results in a better outcome? And these are questions because of the rarity of cancers in pregnancy. We think that should be tackled at the European level. So we started this European project where we're leading the Cancer in Pregnancy Task Force. And any one of you who would be interested, and I know, Ariane, you reached out and you're going to be collaborating, but anyone who wants to collaborate is welcome to join this EU network, where actually this is a little bit a complicated slide, but it only says if you're doing NIPT and you're thinking you have a cancer and you would like to have a second opinion, you're welcome to send DNA. We do this for free back. And then the idea is that you reach out to oncologists who are partnering in this cancer in pregnancy. There's an international and a European consortium of cancers in pregnancy oncologists where we will register, follow up the women, and also monitor the outcome and the results. And the idea is that all together we can that can lead to a better clinical practice, let's say, and a better care of women with pregnant women with cancers. So if anyone would be interested, you can reach out to me or Elisabeth Leenaerts, who's leading the team. And then we're obviously towards the future exploring the potential for fragmentomics. I have a group working on liquid biopsy. And if you ask this game, who is it who's working in your lab on cfDNA, or throw everyone else out, these are the people who've been doing the work. And I thank especially Frederik Amant and Elisabeth Leenaerts from the Cancer in Pregnancy group. Thank you very much.
Thank you very much, Professor Vermeersch, for this interesting talk. Well, there's one question in the chat. How important will be the non-interpretable NIPT in view of cancer detection? Fortunately, it's rare. And
sorry, could you repeat it? Because I was...
How important will be the non-interpretable NIPT in view of cancer detection?
Yeah, okay. The majority, so the non-interpretable is for us. So we have a number of quality parameters. One is the noise level, and the other one is the fetal fraction. In extreme low fetal fractions, we now have a completely different study where we followed up all prenatal tests which failed, and so you have the failure because of low fetal fraction and because of noise. And what we show in that study, which hasn't been published, but which will come out soon, I think, is that the majority of these cases are actually autoimmune diseases. So autoimmune diseases target different tissues, give different fragmentome patterns, and as we heard previous talks, they give noise in the signal we usually see, and that's actually the major bulk of the non-interpretable results. So if you look at the other set, you're absolutely right. So on the one hand, you have the copy number variants, and I think that's very clear. If you have such high copy number variations, that it must probably come from a cancer. I don't know any other cause. Sometimes we see single chromosomal aberrations where we do not yet know where it's coming from. It's not from the white blood cells, so we're wondering, and we're actually studying where that is coming from. And then I think some of them may well be cancers which are under the detection limit of the copy number alterations, and the future will tell. But I think it's worthwhile to follow that up, and that's also good reason to participate in this network, so we can actually do this together. Yeah.
But for the community out there, it's a rare event, and there are many other good reasons why an NIPT is not working, and it's detecting every high cellular turnover, and there are many other reasons why it can be. So thank you very much again for this talk, which is interesting and important.